We are continuing, inshallah, the revision and the cases, and I wish everyone is enjoying. And I was trying to make some food, cooking some food, but yeah, the result wasn't very nice or very moderate, yeah. But let's start. Let's start the cases better. So, what do you think about this case? Okay, the voice is clear. Okay, so this lumbar spine, AB view, and there is Muayyad, Nermeen, nice, in the right side. So what is your differential diagnosis according to this finding? And we can consider it not obvious. I mean, you have something here. I agree with you. According the pedicle of L4, yes. So what it could be? Can you give any differential? Okay. Yeah, it can be MITS. What else? So in the right, L4 pedicle and transverse process, sclerosis. And there is, I wait someone to comment, there is some scoliosis, right? Yeah. So MITS, lymphoma, osteoma, perfect, nice, good differential. So scoliosis, sclerosis, there is any relationship? What it could be? Final? According to this image, they like in the MCQ to ask you about the cause of painful scoliosis. So now you know the cause. Why? So you can see the CT images. Yes, osteoma. So the famous one, osteoma, you can see that already this patient. And when you go to the sagittal images, yes, exactly. And in the coronal images again. So you have many, and it have the central nidus and the right L4 neural arch surrounded by some sclerosis. And they say that maybe histological confirmation by CT guided biopsy in the management, or surgical excision, or maybe you can mention that can also have treatment by RF, radiofrequency ablation. In this case, they make something called preoperative embolization. You can see the catheter and they inject embolizing material. So you know about the osteoma, it is benign tumor. It should be similar to osteoblastoma. Yes. but different size. So which one is bigger, osteoblastoma or osteoma? Exactly, osteoblastoma is bigger, nice, in size, and more aggressive, and it can transform to malignant entity. So the osteoblastoma, bigger in size, more aggressive, and can transform to malignant entity. The usual age of osteoblastoma between 20 to 30 in age, male predominance. Osteoblastoma may be younger age. I mentioned to you that when you see the painful scoliosis, as in this X-ray, or you see scoliosis with sclerosis in one of the pedicles, then maybe it gives you a clue to think about other differential than metastatic lesions. You know that the pain respond with non-steroidal or aspirin. Most of the lesions, like the posterior neural arch or posterior element. So when you see scoliosis again and you find this sclerosis, you give a rise or give a clue for you to think about osteoblastoma or osteodysteoma. Yes. They mentioned that usually the congenital scoliosis with female predominance, and it is non-painful, different from the male predominance. Yes. Radiological feature the same. Okay. And as we mentioned that in the CT, it can have vascular nidus, and sometimes they go through preoperative embolization. Okay. The angiography, as in this case, is not as a routine to be involved in this case, is not a routine as a routine of investigation. And the hypervascular blush, it can happen with everything, is non-specific. Let's go to another case. Which is selected MRI image. So which sequence you have now? T2, T1, or yeah, T2. So let's try to describe first what it is, how you describe it. Okay. So how you describe it? Yes. There is, try to describe with me to train yourself. So there is mass, yes, high signal. If you consider the myometrial signal, so it is high signal, and extending to the endocervical gland, the endocervical canal, sorry, and extending to the uterus. The canal is obstructed. Yes, the canal is obstructed. Perfect. Endometrial widening or obstruction. I think you mean obstruction. Yes. And the endometrial canal is obstructed. Yes. There is distension of the uterus, and it look like hydrometra, whatever the content. You need the other sequence to prove that it is fluid. But okay, if you consider it as fluid, so it will be hydrometra. You can see that the bladder is empty, and you need more images to check for any infiltration of the surrounding. but consider that there is no infiltration. Okay, so I see that the first differential for you would be cervical cancer, as you mentioned, but it's important to mention that there is uterine involvement. So if you didn't mention that there is uterine involvement, you will miss some marks. And also you mentioned the distension along the uterine cavity. Differential diagnosis could include, what could be included in differential diagnosis? Yes? Amna, nice. Huda, Nermeen, our stars. We miss our stars, والله. Khalid, Huda, Muayyad. Okay, so yeah, it can be polyp, but in this case, to be honest, it's very difficult to be polyp, but you can make like a differential because there is invasion and aggressiveness. So the malignant process will be the dominant here. It can be cervical lymphoma or metastasis, which is not common, but it can be. Okay. The management, they like to mention in the for the FRCR that urgent referral for the gynecological team and MDT approach. Maybe you need to do ultrasound. Why? Yes. Thank you, Amna. Yes, we are going now to the next step now. Why you need to do ultrasound for? Yes, for staging. Which staging you need to confirm? Exactly. Which organ? I mean, the ultrasound is not for a routine for staging, but I mean, which, yeah, for the ureter, you need to check for there is any hydronephrosis or not. Yes, but in general, you will do MRI for local staging. So the staging will be by MRI, and for distant staging, you will do CT or PET-CT. Yes, according to the protocol of your hospital. But in most of the hospital, they go through CT chest, abdomen, pelvis for distant detection. So the local staging by MRI, then it can be treated by radical surgery or advanced chemotherapy, chemoradiotherapy, according to the staging. They like to mention in the staging the importance of the 2 and 3, because you know is different management. So according to there is any parametral invasion or not. If there is parametral invasion, so you are going to be in 2B. Yes, 2B. And you can remember that B for parametral invasion. So 2B for parametral involvement. And 3B again, it reaches the pelvic. Yeah, the pelvic wall. So you can imagine that 3B, it will have what is called hydronephrosis because it reaches the pelvic wall in the sides. Okay. Let's see one example for the parametral invasion because I think is important for the practice and the exam. So I will show you something now because it's important to mention that there is parametral invasion or there is no parametral invasion, and you lose marks for the exam, and in the practice the clinician will not be very happy from you. So you need to make the clinician happy to mention what he needs. So you see now what happened with the parametral invasion. So if you would like to say the staging, what it will be the staging here? Is it 2B or 3B? We mentioned that B is for parametral and for 2. For 3, it will reach the pelvic wall. So you consider it as 2B or 3B? Yeah, 2B. Why? Because it doesn't reach the pelvic wall, so that's just 2B. But there is parametrial invasion. Yes, there is extension with parametrial invasion. Okay, I will try to show you something else more obvious. Maybe this one. Okay, so now look in this one, and you can see that which there is also again there is parametrial invasion. You see? Yes, there is extension outside the confinement of the low signal ring. Here also I can show you some examples of the how it look the parametrial invasion. You see, it should be there is one ring here surround the cervix, which is in our case, but is sagittal, this ring, which is low signal ring. But when it's disrupted, the mass going outside, and when it reaches the pelvic wall with hydronephrosis, so you are going to mention that it will be 3B. Okay? Is it clear, or you need more examples? So when you find the, I will show you one more example, then I will be sure that. So now, if you make a staging for this case, so what do you think about this one? So there is hydronephrosis and there is parametrial invasion. So according to our staging, there is parametrial invasion, but not involving pelvic wall. But in 3, extension to the pelvic wall and or hydronephrosis. So when you find the hydronephrosis, you are going to mention that it is 3B, right? And they add something in the new staging that there is 3C. And when it reaches with para-aortic metastasis and pelvic lymph node metastasis, so it is 3. So take care about this. Anyway, the most important for the exam to remember the difference between 2 and 3. When it is the B, remember the B for parametral or pelvic, okay? When it's just parametral without pelvic, then it is 2B. When there is extension to the pelvic, especially the ureter, okay? So you are talking about 3B. The A is denoting that about denoting the extension to the upper 2/3 vagina, either in 2 or 3. Okay, so if it is limited, so it will be A 2. If not limited, it will be and extend to the lower third of vagina, it will be 3A. I wish that you enjoy it. Anyway, I know that difficult and you can revise it again, but at least know the difference between 3 and 2 in B, the most important for the exam and practice. Okay, let's go. Yeah, this case have also coronal image. I will show you. It can help you to see the right parametral extension. Yes. Okay. Let me check if there is any more questions for the MCQ. Yeah, the human papilloma virus, you know this, cervical cancer, the third most common gynecological malignancy. Human papilloma, yes, they have some strains. Majority of cervical carcinoma, squamous cell carcinoma. Yes, squamous cell type. And just 15% is adeno and other type. The most important in the MCQ, I told you the FIGO staging. We already talk about it and how to differentiate between 2A and 2B and 3B and 2A and 3A. The ultrasound rule is limited, but you can assess the hydronephrosis. The CT is important for distant metastasis, as we mentioned. The MRI is the golden rule in this case. Okay, let's go to the next case. Okay. So this pediatric age group patient, you can see that he did this, what is called micturating cystourethrogram, MCUG. So this is selected images. Yes. Nermeen, Huda, Amna, yes, active stars, our active stars, yes. So MCUG, right-sided vasoguroteric reflux. So you'd like to check for any other images. Okay, I will show you. So at least we have dilatation in the right side uterus. And I think you want to go up to see the rest of images. I will show you. So there is dilatation in the ureter and dilatation in the renal pelvic calyceal system, right side. So there is calyceal blunting. So grade 4, perfect. So there is a flux, dilatation, grade 4 reflux. Okay, what else? So you check more images and see what is going. You will check for urethrocoel, perfect. So rounded, when you describe it, rounded, lucent, filling defect within the bladder. So there is reflux. Which moiety you are expecting? Lower moiety or upper moiety? I think I gave you the answer now. So yes, when you find urethrocoel, which moiety? Reflux in the lower, perfect. So lower moiety, urethrocoel with reflux. So what you expect now? Exactly. So there is reflux in the lower moiety. So the duplex right kidney, this is what you expect. So if you go now, you will see the dropping Lilly sign, dropping Lilly sign, inferior displacement, and absent upper pool calyces. Yes. So, and if you go to the bladder again, in this view, you check for the posterior urethral valve. There is no posterior urethral valve. So there is reflux in the lower moiety of duplex right kidney. There is urethrocoel of distal ureter, but without reflux. So there is, yes, urethrocoel associated urethrocoel, yes. Let's go to some other images. So you can see the right kidney by ultrasound. Yes. So there is hydronephrosis of the upper or lower calyces. Yes, there is upper hydronephrosis. So upper bore calyces have hydronephrosis, and in the image of the bladder you can see bulging, something bulging in the posterior wall of the bladder. So like fluid field structure, maybe ovoid or tubular, and this appearance of the dilated ureter, distal ureter with urethro-C. So the final diagnosis will be duplex right kidney with obstructed upper moiety and there is associated urethrocoele and reflux in the lower moiety. Is it clear? So the management in this patient, they mentioned that they will make treatment course of antibiotics immediately after the MCUG, and he will keep on prophylactic antibiotics, then make referral to the pediatric urologist. They mentioned that the DEMSA scan will be as a normal part of the workup of this patient who assess the renal function. So the duplex in general is a common case, either in the exam or in practice. And you know that there is association with Mullerian duct anomalies in the females because the concurrent development of the urinary tract as well. Yes. So the renal tract should be evaluated in these cases. Okay. The renal duplex can present with several prenatal or postnatal. They like to do for these cases MCUG, ultrasound, and DEMSA scan. So keep this in for the FRCR. They mentioned that in these cases, as a routine, MCUG, ultrasound, already this patient did it, and DEMSA scan to assess the renal function and guide the management. You know already that the duplex kidney is larger than the normal kidney, and there is some single collection. Yes, you know the Vigart-Meyer rules. Yes, the lower moiety. Yes, someone he can mention it. The Vigart-Meyer rule. Lower is insert where? Orthotopic or in abnormal? The lower moiety. Yeah, the lower moiety insert in orthotopic position, while the upper moiety insert in ectopic. Yes, lower, inferior, and medial. So this is the normal position. But the upper one is inserting in ectopic position. Yes. So the upper moiety can insert in ectopic position. It can going in the bladder neck. It can proximal to the urethra or vagina. So that's why the upper moiety is prone to have, or more common to have, what is called the erythrocoel and the obstruction, as in this case. As you see, in this case, it have the upper moiety who have the obstruction, right? So the upper moiety is more prone to have the erythrocoel because it go in ectopic position. Yes, upper ectopic, lower reflux. Perfect. R with R. Yes. And the lower moiety is more prone to reflux. R with R. Reflux in the lower moiety. Okay, so I see that everyone is knowing this. Already we see how it look in the MICTE rating, and you should comment in the posterior urethral valve and say that is normal and there is no posterior urethral valve. Okay, let's go to the next case. We have less than 1 minute and we will shift to another case, okay? Okay, so this patient, pediatric age group, and what do you think? Chest radiograph, frontal chest radiograph. To avoid any mistakes, try to describe first, as we mentioned always, and then after that, put your differential diagnosis and finally management. So go in a systematic approach to avoid any mistakes that it can give bad impression if you just rush and give any diagnosis. Yes. So better to go through your approach with checklist. And I see that everyone want to comment in the bones. So how we describe these bones? I mean, I would like really to mention all what you mentioned in the chat, but is a bit, yeah, maybe there is, okay, less than 1 minute. We'll take break for 1 minute and come back, okay? And I see that in the comment, appearance of the ribs, I agree with you. And it looked like thickened or brooded, I agree with you. And the lungs look like a bit normal, no pneumothorax. And before everything, you should comment in the nasogastric tube, and it is in situ. Yes. So you should start with the tubes and the lines. And the tip, it look like below the diaphragm in good position, so it is in situ. But the thing that you should maybe you can mention that there is multiple rib fractures with different ages. Yes. So multiple rib fractures with different ages, brooded, beaded ribs. I agree with you, Huda, that you will put non-accidental injury as good differential diagnosis. And the other differential will be this pediatric age group, baby present with failure to thrive, osteogenesis imperfecta, wide, perfect. So either non-accidental injury or osteogenesis imperfecta. So you need to have in management urgent discussion with pediatric clinician. Need to consider skin biopsy, fibroblast culture, expert pediatric radiologist may be needed in this case, and finally skeletal survey. You know that osteogenesis imperfecta, type of genetic disorder, autosomal dominant. They have along 4 to 5 types, from mild to severe, mild, severe, moderate, and so on. As you see here in this case, present with multiple fractures, variable ages, Wormian bones, basilar invagination in the skull, and in long bones you can see cystic metaphysis. Okay, so this criteria of osteogenesis imperfecta. Maybe just show you something. Very quickly to remember it. So you remember this appearance, osteogenesis imperfecta. It have many presentations along the metaphysis, long bones, cystic appearance, fractures, multiple fractures, can present with this. And you know that it sometimes with differential with other types, and is can associated with kinky hair syndrome, acrosteolysis, cleidocranial dysostosis. So Wormian bones, fractures again. Okay, you have many appearance. Okay, Wormian bones, skull invagination, basilar invagination, thin bones. The Wormian bone is small irregular bones that it is present in the sutures, within the cranial sutures. Anyway, it have many appearance, many shapes, imaging features. Let's go to next case. So breast imaging. Right side, mediolateral oblique. Left side, and right side again, craniocaudal. And left side, craniocaudal. So this breast, you can consider it as, in the density, is dense breast. So ACR C, or maybe more. And what do you think about the left breast? There is need to make some zooming. There is some micro calcifications. I know that you need to use zooming lens to see the micro calcification. What is obvious here, the macro calcification, I agree with you. But there is some some micro calcification there, okay, in the upper outer quadrant of the left breast. And there is other variable calcification, which is macro. The micro, some of them are branching and linear, then which is malignant microcalcifications. You know the suspicious types. So this is one of the suspicious types. I mean the linear branching microcalcifications. The right breast, it looks like normal. There is no calcification, no malignant calcification. So the right breast in the BI-RADS, maybe it can take BI-RAD 1, but the left breast in the BI-RADS until now, it will take at least BI-RAD 4C or maybe 5. But I agree with you that the microcalcification is not very obvious, need station and it need much. I will show you some types of suspicious microcalcification, don't worry. And if you consider the microcalcification in this case as malignant, you know that it will be the management triple assessment for the FRCR. You need lateral mammogram, magnification views. That's what I told you now. I will show you some magnification views now. I hope I can find something easy. And it should be examined by ultrasound. If you didn't find by ultrasound the microcalcification, so in this case, you cannot take biopsy. So what would you like to do if you didn't find anything in ultrasound? What you will do? I mean, you in this case you will go to do ultrasound, right? To check for the calcification and try to take biopsy. But if you didn't find the microcalcification by ultrasound, you didn't find anything. It looked like normal, and you still saw this calcification by mammogram. What you are going to do? So Nermin suggests stereotactic, and I see Hassan, yeah, MRI. So what do you like to do? Is it MRI or stereotactic biopsy? And Nermin, what is the stereotactic biopsy? What is it? Yes, it will be stereotactic biopsy. Perfect. But what is the stereotactic biopsy? So the approach is that when you find this microcalcification or you suspect, you are going to make magnification view in the workstation that you need already to do it in the workstation and to see to use the zoom and the magnification, and you need to do to ask the technician to do a magnification view and lateral view. Okay, and if you did this, you are going to do after that ultrasound. In the ultrasound, if you didn't find nothing, so you cannot biopsy. So you are going to take the biopsy under the guidance of mammogram. So what is called of stereotactic biopsy. It's a special technique under the guidance of mammogram. So this is what is called stereotactic biopsy. Yes. I want to show you some malignant calcifications. I think in radiology assistant, they have very nice explanation. Let me show you quickly. So yeah, you remember the terminal ducts and the acini, the terminal ducts. So when you have lobular calcifications, it will appear like punctate, rounded, or milk of calcium. But on the right side, if it is intraductal, it will be pleomorphic, linear or branching. So this is what we will mention that is suspicious, the linear, branching, pleomorphic. Let's go and see how it looks. Yeah, we already mentioned this. So can be diffuse, regional, clustered, segmental, or linear. You remember we mentioned this before, that the calcification distribution, if it is malignant, if it is linear or segmental, it will be most probably malignant. If it is diffuse or regional, it will be benign, and there is intermediate group. Okay, and there is many detailed explanation. We did it already in the revision. You can go and see the mammography lecture, but in general it was like this. Okay, can show you some benign calcification. For example, let me check for you this one. Yeah, like this, the vascular calcifications is benign one. I know that you already know. And this, for example, what is called popcorn. So this like involuted fibroadenoma, if you remember. And for example, this one is for plasma cell mastitis, rod-like appearance. So this benign again. And as we mentioned, if it is rounded or banqueted, so this for benign again. But sometimes maybe duct carcinoma in situ can have similar shape, so be careful about this. Eggshell calcification, again benign types. Okay, and this is what's called dystrophic calcification, especially when you find some radiopaque clips or markers that this patient did irradiation, so he have after that dystrophic calcification, or as in this case as well, extensive dystrophic calcification. All these types are benign. So what is suspicious? The suspicious one is the amorphous calcification, like this case. So indistinct calcification, you cannot describe it. There is no defined shape or form. So this is what's called amorphous calcifications. They have about 20% of cases are malignant. So still suspicious. There is what is called heterogeneous or coarse calcifications, and the fine pleomorphic calcifications, which is very suspicious. The amorphous fine pleomorphic, again suspicious. And the most important, the fine linear or linear branching. They like it for the MCQ. Highly suggestive of malignancy by RADS5. And for the FRCR, they mentioned that M5. Yes, M5 or by RADS5. Okay? And it can be like high grade of duct carcinoma inside. That's why if you didn't find anything by ultrasound, you are going to biopsy it by stereotactic biopsy. Is it clear? I think we talk enough in this. So I wish that you enjoy the mammography case. In this case, in our case, when they did the lateral view, you can see clearly the in the magnification, you can see the amorphous appearance, linear branching appearance, and here also you can see the malignant type of calcification. Okay. Let's go to the last case in this session tonight. So try to describe, don't give diagnoses, try to make an approach with description. So selected image of post contrast venous phase of CT. Until now it's abdominal. So I will describe it. There is variant. Okay, thank you. Left renal vein, retroaortic. Okay. What else? So Huda, small hypodense in the liver, but I mean choose the obvious thing in the selected image better. So fluid adjacent, okay. There is ascites, okay. I agree with you. Okay. What is this? I would not be very happy if you didn't mention what it is. Okay. Because we have very nice cases before. Yeah, what is? Okay. So I will show you other images now. Dipthic Ashok. Nice, thank you. So there is ovarian adnexal lesions. Yes. Bilateral ovarian lesions. Perfect. Maybe more obvious here. So bilateral adnexal masses. I will not go to the diagnosis now. I want to check first the description, because I think if you are going with this approach, you'll miss much marks. It's better to describe. So there is ascites, there is bilateral ovarian lesions, and what else? What is your approach now? I think you missed already this, because this is, if you have bilateral, yes, peritoneal, DRRR, thank you. You can put it in the public comments. Peritoneal carcinomatosis with calcifications, perfect. So this is what's called omental cakes, peritoneal deposits, peritoneal carcinomatosis. You should describe it as peritoneal and omental calcified lesions. So it is omental cakes. So omental cakes, bilateral ovarian masses, and what else you are missing still? So if you miss like this, you lose some marks. So take care. You have a bit dilatation in the ureters. You need to check, at least to mention that you need to check for hydronephrosis. Perfect. sorry. So at least you check for hydronephrosis, right? To this patient, after 1 year, he come because the radiologist, when he comment, he miss something, so he come with this appearance. What do you see now? Yes, the mental cakes become more progressive, the ascites more progressive. There is left hydronephrosis. There is some lymph node metastasis. Yes. So it become full picture. So, and now maybe what it will be the primary? Can you imagine the primary now? Yeah, it can be the ovary, but the ovary is like bilateral lesions. So maybe you expect maybe it come from another primary. So one of the most important primaries that gave bilateral Krakenberg tumor, it is the stomach. Perfect. So the stomach here, it is the primary. So Krakenberg ovarian tumor, primary gastric cancer is the most probably the first differential. The other differential, it can be others, but with this case, because already you see the progression of this patient, so you have the evidence that it is gastric and there is peritoneal deposits everywhere. So bilateral ovarian masses, and this patient come to you after with this appearance. You need to check the left kidney, and maybe he will need ultrasound guided nephrostomy or nephrostomy in general. Maybe you will need to have guided biopsy for the omental lesion or the peritoneal metastasis, and you will need CT for distant metastatic staging, for staging of distant metastasis, or PET CT. So in this case, it can be primary ovarian cancer, or it can be gastric cancer, but with this appearance and this progression and the stomach mass, so it is primary gastric cancer. Can also be breast cancer if this patient female, as here. So it can happen with many types of cancer that it send bilateral ovarian masses or associated with bilateral ovarian masses. So yes, Krakenberg tumor, bilateral ovarian metastasis. Usually the primary is mucinous tumors, especially mucinous gastric malignancy. Okay. Yes, any mucinous gastric pancreatic colon. I wish that everyone enjoy, and I will, inshallah, see your comments in the group, and if you need anything, inshallah, see you soon. Assalamu alaikum.